Good afternoon to all. So today's lecture of psychiatry is on therapeutics. We will learn what are the modalities available for the management of or treatment of the psychiatric patients. So we will cover history of psychotropic drugs, classification of drugs, interpretation of data of the drugs, drug selection, dose duration and monitoring, treatment outcomes, the drug classes, other than drugs, brain stimulation methods, surgeries, hormonal therapy, and vaccines. So, in the history, these are the few bites. For the centuries, plant extracts and other natural substances used as mood and anxiety influencer and sleep modulator like alcohol, coffee, tea, opium, bromides, hallucinogens. So opiums in 19th century it was used in the soft drinks also and was available over the counter. But the opium is also nowadays used for pain management and others, but it is a restricted drug. The next point is from 1930 to 1950s, the most effective biological treatment which was available for any psychiatric disorder was electroconvulsive therapy. In 1931, two psychiatrists in India described the ability uh, of a plant to reduce the symptoms of psychosis, and later reserpine became one of the first agents to offer benefit to the patient with schizophrenia, which is the extract of this plant. And the two psychiatrists were from India, from Nimhans, Dr. Ganpat Sen and Kartik Chandra Bose. So first ever chemical which was discovered for psychiatric disorder uh, was by the Indians only. In 1949, antimanic properties of lithium salts uh, was discovered, and first breakthrough occurred in 1950 and 1952 when chlorpromazine, which is an antihistaminic drug, was discovered as antipsychotic agent. So collectively, all these drugs which were used in psychiatry or psychiatric disorders were collectively called as tranquilizers because of their sedating effect. In 1952, iproniazid, a drug which was being tested as a treatment of tuberculosis, was observed to cause elevation in mood and was discovered as antidepressant, which is uh, MAO inhibitor. And MAO inhibitors later withdrawn from the practice because of the fatal cheese reaction. First, TCA or tricyclic antidepressant uh, discovered was imipramine, which was the derivative of chlorpromazine and was observed to alleviate depressive symptoms. In 1955, the availability of meprobamate marked the first time that treatment of anxiety and had a relatively wide margin of safety. So this is the brief timeline of discovery of drugs. Uh, Similarly, in 1957, chlordiazepoxide, a benzodiazepine, was found, and in 1958, another chemical family of compound was found, which is known as butyrophenones, under which the drugs comes haloperidol. The first atypical antipsychotic, or you can say second generation antipsychotic, which was discovered in 1950 was risperidone. And these atypical antipsychotics are also known as second generation antipsychotic, atypical neuroleptic, or serotonin dopamine antagonist. On the basis of their mechanism of action, they are also called as SDAs. Zimelidine, the first of these SSRI, which was developed in early 70s. So now the classification and categorization of these drugs. The drugs are classified on the basis of various factors, and one of the major factor is indication. On the basis of indication, these drugs are classified as antipsychotic drugs or neurolapse, antidepressants, mood stabilizers, anti-anxiety, hypnotic drugs, and psychostimulants on the basis of their indication to psychiatric disorders. But the problem with this classification is the classification is not diagnosis specific. Means antipsychotic, for example, olanzapine is also considered as mood stabilizer, and a mood stabilizer, lithium, is also considered as to reducing the suicidal intent in schizophrenia. So interchangeably, these drugs are used, can be used in one from another disorder. And the second point is, not officially recognized agent as psychotropic are used in the psychiatric disorders like clonidine for uh, opium withdrawal, propranolol as to cut the social anxiety, verapamil and pregabalin also for the anxiety disorders. So as a result, reclassification of these drugs being done according to the mechanism of action rather than by indication. So on the basis of mode of action, these drugs can be called as uh, enzyme inhibitor or modulator, ion channel blocker, neurotransmitter releaser, modulators, receptor agonist, antagonist, partial agonist, or reuptake inhibitors. So how do we interpret the data for these drugs? The source of evidence can be many, like randomized trials, controlled trials, open label studies, clinical guidelines, discussion with each other, or our own experiences. But the more accurate data comes from randomized controlled trial and meta-analysis. So these two are the very specific and organized study of any drug, uh, which can conclude the usefulness or other things regarding the drug. And ultimately, in the clinical practice, one have to integrate all the relevant data for individual patient on the basis of the evidence available for the drug. So now the question is how to do a drug selection. So drug is selected on the basis of drug factors itself, safety of the patient, and the factors related to the patient. In drug factors, there are two terms, pharmacodynamics and pharmacokinetics. In pharmacodynamics, considerations include the mechanism of the drug, the dose response curve of the drug, the therapeutic index of the drug. Some drugs has low therapeutic index like lithium should be considered for the dynamics, the development of tolerance to the drug, dependence, and withdrawal phenomena. These things should be considered for drug selection. The adverse reaction should also be considered. On the basis of pharmacokinetics, the onset and duration of drug activity, interaction between the drug that alter the absorption or other factor for the drug should also be considered. The patient-related factors can be response to the medication, sensitivity to the side effect. Some patients are more sensitive to particular side effects, some are not, should be considered. The diagnosis and the genetic loading of the disorder is also considered. Some drugs are recommended if genetic loading is more in the patient, like in bipolar, if genetic loading is more and prevalent in family history, then sodium valproate is preferred than the lithium. Lifestyle of the patient, if person is having sedentary lifestyle and having overweight, then the drug which is not causing the increase in weight can be used. Uh, like in antipsychotic, olanzapine used to cause more weight gain than the aripiprazole or cariprazine. Overall medical status like renal impairment, hepatic impairment should also be considered. Comorbid disorders like diabetes, hypertension, and the past history of drug response is also important. If one person is responded to the one particular drug in the past, that should be preferred in the current episode also. The patient's attitude means aversion to certain type of side effect should be considered. If the patient is working, working on machinery or working as a driver, so sedating agent should not be used in those cases. Patient's family history of drug response is also important. And now, what about the dosing, duration, and monitoring of the drug? Uh, for dosing, the things which should be keep in mind is inherited sensitivity, ability to metabolize the drug. Some people are rapid metabolizer, like for valproate, few individuals have rapid metabolizing ability. Concurrent medical disorder should also be considered. Uh, for example, the drug side effect of one drug may not hamper the profile of another medical disorder. Uh, should be considered. And history of exposure to previous medications. If the history is available, then exposure history should be considered. Now the point is the drug must be used in effective doses for sufficient period. Okay, do not underdose the drug and give an ample amount of time to say the drug is working or not. Subtherapeutic doses and incomplete therapeutic trials should be avoided. And for almost all of the drug, it takes 2 to 6 weeks to act. So before 2 weeks at least, the drug shouldn't be stopped if it is in the uh, adequate doses or otherwise indicated. Time of the dosing is usually based on the plasma half-life of a drug and its side effect profile. Side effect profile, like if the drug is uh, causing more sedation, the drug can be used in the night time or bedtime. If it is causing orthostatic hypotension, then also it can be used in night time or bedtime. The duration of the treatment. Almost every patient used to ask this question, that how long do I need to take the medication? Uh, the answer is, of course, depends on multiple variables like nature of the disorder, whether it is long lasting or it remains there for the short period of time. The duration of symptoms, how long is the illness is he is having, the family history, tolerability of the person, and benefits of the patient which he is having with the drugs. So risk benefit ratio should also be considered while duration of treatment is discussed. For most of the psychiatric disorders have high rates of chronicity and relapse. And because of this, long-term treatment is often needed for psychiatric disorder. But it is not always the case. Sometimes it is required for the shorter period of time also. So the treatment in psychiatry is usually broken into 3 steps. Uh, the first one is initial therapeutic trial, continuation phase, and maintenance phase. In initial therapeutic trials, uh, is for observing the effect of the drug on psychopathology, then continuation phase and maintenance phase for prevention of relapse and recurrence of the illness. Now the treatment outcome. You have put a patient on medications, then how you will observe the outcomes, various outcomes of the treatment or management. The goal of psychotropic treatment is to eliminate all the manifestation of the illness. So a holistic approach should be made to combat with the various symptoms. Sometimes some symptoms are not uh, being controlled by a drug, so that the second or third study should be considered to control or alleviate those symptoms. In treatment outcomes, remission is called as the degree of improvement below the syndromal threshold. When the psychopathology is severe and crossing the syndromal boundary and diagnosed as a disorder, when you are going to treat, you are treating a disorder and the symptoms are now subsyndromal. A syndromal diagnosis cannot be based on the criteria of that disorder. Then the patient is in remission. If the patient is improved but do not experience a full resolution, are considered to be responders. So in depression, response is usually defined as a 50% or greater decrease from the baseline on a standard rating scale. But this for the previous periods. But now the scenario has been changed, and the improvement is not calculated on the basis of reduction of symptoms on a scale. It's a holistic approach to say the person is responding. The two terms relapse and recurrence. While you are treating the patient and patient is not recovered fully from the disorder, and in between the patient start having the symptoms again starting increasing or developing, then it is called as relapse. When the patient is in remission, the disorder is now the patient has touched the baseline of the personality, and again the symptom recurs after remission. It is called as recurrence of the illness or disorder. Treatment failure is also a type of outcome. Uh, the repeated drug failure should prompt reassessment of the patient. If you are treating a patient and the patient shows no response or failed response, you should consider the diagnosis first, whether your diagnosis was correct or not. And second, observe for the adverse effects. The adverse effects are also a common reason for non-compliance. For example, achiniasias, which resemble psychotic withdrawal, or akathisia and neuroleptic malignant syndrome. Means adverse effect may mimic as the psychopathology. So you should look for the side effects. The patient is complaining of side effect. You might consider those things as psychopathology. So do consider the adverse effect of the treatment or drug. Intolerance of the side effect may be most common reason for treatment failure. This is the case of non-compliance. Third, the appropriate dose. If the person is not being given appropriate dose of any drug, the response may be not, which is wanted by the person and the doctor. Fourth is if any kind of interaction between drug to drug is reducing the efficacy of the treatment, should also be considered. Non-compliance of the patient. Another outcome is treatment resistance. When you have ruled out all the possibilities of non-response or treatment failure, the some patient fail to respond to repeated trial of medications, and no single factor can explain the ineffectiveness of various interventions in these cases. Means you have tried adequate doses, adequate time of trial of a drug. You have ruled out the non-compliance. You ruled out the interaction. You ruled out the metabolizing ability of the person. The person can be labeled as treatment resistance. For treatment resistance, the strategies which are acquired is switching to the another drug. Drug combination can be tried. Relatively high dose therapy can be given, and treatment for a particular drug can be extended to 2 months. This means it takes 8 months to declare a patient treatment resistant. Tolerance is another outcome. Tolerance is needed to increase the dose of a drug to maintain clinical effect. And commonly it happens with benzodiazepines like clonazepam, lorazepam. And this phenomenon is used as a basis of starting some drug at subtherapeutic level. So the uh, tolerability is not coming to the picture. And drug with similar pharmacological action often exhibit cross tolerance. Means if you are giving one benzodiazepine and replacing another, the cross tolerance may be observed. Sensitization. It is the reverse of tolerance and is said to occur when there is an increased sensitivity to a uh, drug effect over a period of time. And for most of the psychotropic drugs, the therapeutic index is high. Withdrawal phenomena with the drugs. Withdrawal symptoms can occur in uh, the treatment phase when person missed the dose or stop the drug suddenly. The drugs which are having shorter elimination half-life are more prone to withdrawal symptoms and can result from missed doses. So, person may complain of relapsing the symptoms, but actually these are the withdrawal, which will occur in the immediately stop after immediately stopping the drug or when the dose is missed. Usually, relapse doesn't occur immediately after stopping the drug. It takes weeks and months. So, do consider these are the withdrawal of the drugs. Withdrawal can also occur by auto-inhibition, like paroxetine. Paroxetine is metabolized by cytochrome P450 and is also inhibitor of this enzyme. So auto-inhibition can also cause withdrawal of the symptoms. Poor bioavailability with the generic agent is also a cause. Usually symptom resolves within few weeks, so the persistence of symptoms argues against withdrawal. If the symptoms continues for a prolonged period of time, then you should consider for psychopathology rather than withdrawal of the drug. So these are the classes. First one is antidepressants. Antidepressants has various classes like SSRI, SNRI. SSRI is selective serotonin reuptake inhibitor. Examples are fluoxetine, paroxetine, escitalopram, sertraline. SNRIs are duloxetine, venlafaxine, desvenlafaxine, milnacipran, levomilnacipran. Tricyclic antidepressant examples are amitriptyline, still in uh, use but in the lower doses. Clomipramine is also used for OCD nowadays. Uh, MAO inhibitors like phenelgine, seragine, and the third one is not in the use now, are rarely used. Atypical antidepressant, which has a different mechanism of action, like bupropion, nifazodone, vortioxetine, trazodone, and mirtazapine are another class of drug. So look at this picture, how the antidepressant acts. The point number one is for reuptake inhibition. When in the synapse, neurotransmitters are available which had been blocked for to be reuptaken in the presynapse. So SSRI acts here and TCS acts here. The second point is autoreceptor. The autoreceptor, when you give a drug, there is ample amount of neurotransmitter in the synapse. Then autoreceptor sends the biofeedback mechanism to the presynapse that more receptors are available. Then start reducing the production of neurotransmitters. So here is the mechanism of autoreceptor. The MAO enzyme inhibitors acts on monoamine oxidase, which are present in the presynapse, where the metabolism of neurotransmitters are blocked. So availability is increased in the presynapse for release of the neurotransmitter. So this is the dosage chart for SSRI. Fluoxetine is 40 to 80, paroxetine is 40 to 60 milligram, and sertraline is 150 to 200. The commonly used amitriptyline is 150 to 200, and others are bupropion 200 to 300, mirtazapine maximum up to 45, and venlafaxine is for 150 and 225. These are the side effects of antidepressants. Uh, the cholinergic side effects are dry mouth, urinary retention, blurred vision. Others are constipation, sedation, sleep disruption, weight gain, headache, nausea, GI disturbance, abdominal pain, inability to achieve an erection, inability to achieve an orgasm, loss of libido, delayed ejaculation, agitation, and anxiety. So these side effects should be keep in the mind, particularly the sexual side effects, which are more cumbersome to the patient. This is the classification for antipsychotics. Here is the first generation, second generation, and third generation antipsychotics. First generation is divided into three: butyrophenones, phenothiazine, thioxanthines. And the second generation, the common drugs are clozapine, olanzapine, risperidone, quetiapine, which are being used, and uh, lurasidone. The third generation atypical antipsychotics is aripiprazole and cariprazine. These are the partial agonists of the dopamine receptors. In psychosis, the activity of dopamine is increased. So, by blocking the dopamine receptor, the antipsychotic drugs acts to reduce the dopaminergic activity. This is the dosage chart. For common drugs, aripiprazole maximum dose is 30, uh, the required dose is 10. Clozapine is 125, 12 point starting doses 12.5 and can go up to 900 milligram. Haloperidol up to 10 milligrams, and for olanzapine it is 30 milligram, and risperidone is 6 milligrams. These are the common drugs. The side effect of first generation antipsychotics include muscle rigidity, significantly slowed movement, which are the uh, collectively symptoms of EPSCs. EPSCs is known as extrapyramidal side effects, which are caused by blockade of dopamine receptor in nigrostriatal pathways. Extreme restlessness can occur, like known as akathisia. The long-term side effect, tardive dyskinesia, is also caused by the long-term use of antipsychotic. These are the involuntary movement of the face, especially around the mouth and lips. NMS is a fatal and serious side effect. It is often life-threatening condition characterized by muscle rigidity, fever, sweating, and autonomic instability. For second generation, the side effects common are sedation, dizziness, weight gain, sexual dysfunction, cardiac effects like QTC prolongation, hypotension, dry mouth, and constipation. And for third generation, the common side effects are nausea, vomiting, headache, insomnia, constipation, tremors. So you can see, uh, moving from first generation to third generation, the side effect of the drug is changed. The profile of side effect of the drugs classes are changed, and it is minimal in the third generation. Like EPSCs are rare, NMS are rare, and other problematic uh, side effects are rare in this third generation. Now, in the mood stabilizer, the anti-epileptic drugs like valproate, carbamazepine, lamotrigine, and oxcarbazepine are the widely used drug for treating mania. Okay. Other have plus and minus results, are not classified as mood stabilizers. Another mood stabilizer, which is not in the class of anticonvulsant drug, is lithium, And lithium has a narrow margin of safety. You can see here for maintenance therapy, zero point 0.6 to zero point 0.8 milliequivalent per liter of drug is required in the blood, and for acute mania 1 to 1.2, and more than 1.5 is considered as toxic level. So it has a narrow therapeutic index, and regular monitoring is required for lithium. This is the mechanism. Lithium acts on GSK3, which is known as glycogen synthase kinase 3, and valproate acts on HDAC, which is known as histone deacetylases. The common side effect of lithium is dizziness, drowsiness, tremor, difficulty in walking, dry mouth, increased thirst, urination, nausea, vomiting, loss of appetite, rash, or blurred vision. In case of toxicity, when the level are more than 1.5, uh, these symptoms can be seen: fine tremors of limbs, cogwheel rigidity, polyuria, polydipsia, agitation, confusion, and delirium. When it is more than 2.5, delirium, stupor, clonus, seizure may ensue. QTC interval prolongation can be seen. Renal failure may occur. Respiratory complication may occur. Eventually, coma or death are the common consequence of lithium toxicity. In lithium toxicity, recently we have managed a case on hemodialysis whose serum lithium was 3.77. So this is the treatment for lithium toxicity. The mainstay is to hydrate the patient, and the diuresis is used to eliminate the lithium fast from the body. And if the level are more than 3.3 or 2.5 with symptoms of delirium, agitation, confusion, dialysis can be started. An adverse effect of commonly prescribed mood stabilizer in the group of anticonvulsants are for carbamazepine, it is nausea, dizziness, drowsiness, dry mouth, constipation. Serious side effect of carbamazepine is worsening of depression, suicidal thoughts, severe dizziness, swelling, itching, or trouble breathing. Uh, for lamotrigine, these are backache, chest pain, cramps, inflammation of the nose. Serious side effects are altered mental state, Stevenson-Johnson syndrome. For sodium valproate, it is nausea, vomiting, pain, dizziness, drowsiness, blurred vision, and hair loss is the symptom of concern for females and for males also. Change in appetite and weight gain. The serious one are confusion, easy bruising, unusual bleeding, worsening of seizure, flu-like symptom, bone marrow suppression, and fulminant hepatic failures. Now coming to the anxiolytic drugs, the main class is benzodiazepine. The common examples are diazepam, flunitrazepam, lorazepam, alprazolam, and clonazepam. Midazolam is used in anesthesia. So the side effects of anxiolytics are dizziness, drowsiness, confusion, nervousness, loss of appetite, feeling depressed, inappropriate behavior or mood swing, and risk of addiction is there with benzodiazepine because of the tolerability. So if you have to give this drug, give for a shorter period of time and withdraw after the effect of another drug is achieved. Breathing difficulties can occur due to impaired ciliary movement in the trachea. Liver failure may occur due to anxiolytics like benzodiazepine, and in case of alcohol withdrawal syndrome, it is tricky to give benzodiazepine because already the patient is hepatic compromised because of the alcohol, and you have to give benzodiazepine as a substitution therapy. So the conclusion is tolerability and safety of the patient often becomes the determinant of treatment success. or failure by the uh, it was concluded from a CAT study and study trial of the antidepressants. The other drugs which are not known as psychotropics or neuroleptics, which are used in psychiatry, is thiamine in case of alcohol dependence to replenish the deficiency, baclofen as an anti-craving drug, acamprosate as an anti-craving drug, disulfiram as an aversive agent for the prevention of alcohol use relapse. Opioid agonists like buprenorphine, tramadol, tapentadol are used as a substitution therapy. Clonidine are used as a central sympatholytics. Opioid antagonists are used as blocking agent to prevent the relapse. Dopamine reuptake inhibitor bupropion is also used for, it's an antidepressant which is also used for anti-craving agent for tobacco dependence. Further, for dementia and Alzheimer's, cholinesterase inhibitors are there, NMDA receptor antagonists are there, phosphodiesterase 5 inhibitors, drugs like sildenafil, tadalafil are used for erectile dysfunctions. Sympathomimetic agent like methylphenidate is used for attention deficit hyperactivity disorder in children. The drugs which are used to counteract psychotropic induced side effect or adverse effect are exemplified here, like antihistamine are used for extrapyramidal side effects, dystonia or akathisia. Anticholinergic drugs like trihexyphenidyl are also used for extrapyramidal side effect, dystonia and akathisia. Dantrolene is a postsynaptic muscle relaxant is used in neurolap malignant syndrome. Dopamine agonist bromocriptine is used in neurolap malignant syndrome or and in hyperprolactinemia due to antipsychotics. So this was all about the drugs. Now coming to the brain stimulation method as a modality of treatment in psychiatric disorders. These are the examples of brain stimulating methods: cranial electrical stimulation, electroconvulsive therapy, PDCS, TMS, magnetic seizure therapy, implanted cortical stimulator, deep brain stimulator, or vagus nerve stimulation. These modalities are can be used for psychiatric disorders, starting with the electroconvulsive therapy. In electroconvulsive therapy, a small amount of electricity is passed through the brain, which induces a therapeutic seizure. You know. And it has been seen that for depression, bipolar disorder, schizophrenia, and catatonia, this therapy is beneficial for the patient. Nowadays, only modified ECT can be given to the patient. Modified means the ECT must be given under the anesthesia, which is provided in the Mental Health Care Act 2017. CES, uh, it is usually called as electrosleeve. The current passed through this device is much lower than the electroconvulsive therapy, so this induces only sleep. This is the device. Transcranial magnetic stimulation, known as TMS, uh, and this is magnetic seizure therapy. Magnetic seizure therapy means the seizure is induced by the high powerful magnetic stimulation. Now, deep brain stimulation and vagus nerve stimulation introduced about a decade following the first trial of TMS. So, this is first approved by US FDA in 1997 for the treatment of neurological conditions like to reduce the frequency of epileptic seizures, essential tremor, and Parkinson's tremor. But later, it is introduced to psychiatry also and found useful in uh, treatment resistant severe obsessive compulsive disorder. These are the picture of DBS and VNS. Now coming to the psychosurgeries, in the era when uh, understanding was not so developed, there are the traces of documentation of trephination, which used to be performed on psychiatric patient. But later development of another new modalities like ECT and chlorpromazine and other drugs, the psychosurgery is the last option for the psychiatric disorder and with the consensus of multidisciplinary team. So it is performed in small, highly selected group, and when the multidisciplinary team thinks that the patient is fit for the surgery, then only the surgery can be done. There are the few examples like subchordate tracheotomy is used for OCD and major depression. Anterior cingulotomy is for depression and OCD. Limbic dichotomy, depression, OCD, and anxiety disorder. Anterior capsulotomy for OCD, depression, and anxiety. So mainly these surgeries are for depression and obsessive compulsive disorders. Reproductive hormonal therapy is also available, like in the premenstrual dysphoric disorder. Gonadotropin releasing hormone agonist can be used, the compound which reversibly suppress the pituitary secretion of gonadotropins, FSH and LH. So it comes from the ovarian steroid secretion. Estradiol can be used in perimenopausal depression or in postpartum depression. Androgen administration can be used in midlife depression in both men and women and is characterized by a steady decline in the production of androgen. In the last vaccine development of vaccine, particularly in relation to tobacco dependence, are in progress. No conclusive data till date can be drawn, but the thing is in the pipeline, and in future this may be available for tobacco dependence and other disorders. So to summarize, follow the general guidelines of psychopharmacology while treating the patient. Introspect in case of treatment failure. When the treatment is failed, consider the cause of failure to declare the patient as a treatment resistant. Consider dependence potential in case of tolerance, particularly with the benzodiazepines. Various classificatory drugs are available for various disorders. Keep in mind the other related drugs which are used in psychiatry. Brain stimulation method and psychosurgeries are available. Biological therapy, hormone therapy can be option in related disorders like postpartum depression and all. And the vaccines are being developed. Thank you.